Well, the current guidelines from the AUA, American Urologic Association, is a yearly PSA starting with a baseline around the age of 40. Now, a lot of practitioners, including myself, probably will push that back to about the age of 45, and certainly by the age of 50. There are different guidelines depending on various organizations, but I think for the most urologists will include age of 45 and then yearly thereafter. Well, what a PSA test evaluates is the blood levels of a protein produced by the prostate. And these levels we can then set a number value to and assess somebody's risk for any prostate health related issues. Prostate cancer is obviously our biggest concern, our biggest focus with this. And somebody with an elevated PSA is going to be more likely to have prostate cancer than somebody with a lower level. The baseline PSA I'm referring to is a baseline for that patient. We no longer consider a normal PSA or an abnormal PSA based on a set number. It has to do with that patient, the age of the patient, the size of their prostate, their previous PSA levels are all very important. For instance, a PSA of 4 can be perfectly normal for one patient and abnormally high for another patient based on those factors. What happens during a PSA test is a blood test, just like getting your cholesterol checked or any other basic electrolytes. It's a blood draw. It then goes to the lab, and we actually have the results back fairly quickly, usually within 24 hours. The next step for the PSA differs a lot depending on the individual. For instance, if you're at your primary care office, the PSA is normal, your exam's normal, he'll just see you back on a yearly basis. On the other hand, if the PSA is high or if there's concerns, then a consultation with the urologist will be sought at that point, and he'll talk to you at that point about whether to proceed with a prostate biopsy or prostate ultrasound. Well, the PSA test after diagnosis and after treatment of prostate cancer is very important. It's what we use as a gauge for the efficacy of the treatment and whether that patient has any ongoing concerns. After prostate cancer surgery, for instance, the PSA should be essentially 0. Now that's different for other treatment modalities like radiation or hormone treatment. Then the level of PSA will depend on the individual, and like we said before, we follow the PSA levels over time. Well, the PSA should never be used by itself. It's always combined with the prostate exam, and then at that point you undergo a consultation with your physician whether to proceed with a prostate ultrasound and biopsy. There are other tests that can be utilized also. They're much more specific tests and usually will only be performed by a specialist. A couple of them are the PCA3, which is a urine-based test. We use that to follow men who've had a previous biopsy whose PSA continues to rise. We also look at what's called a free and total PSA. And this breaks the PSA down into 2 different components and gives us a ratio or the likelihood of somebody having prostate cancer. There are some other tests, but those are the main 2 that we use to follow patients with abnormal PSAs. Yeah, I believe what you're referring to is what are the high-risk groups for prostate cancer. And clearly family history is the biggest group. Anybody with 2 or more male members of their family has prostate cancer needs to start their testing at least by the age of 40. The other group is African American men, a little controversial there, tend to have higher grade cancers, but not necessarily earlier cancers. The other group has to do with obesity and other lifestyle changes like high-fat diets, high-fat meals, those type of things can make you more prone or more likely to have prostate cancer. And we tend to be a little more aggressive in pursuing biopsies or following those PSAs a little more closely. The PSA has been in the news quite a bit lately regarding the controversy of the test itself. And we have to remember that PSA is still the most accurate way of diagnosing and screening somebody for prostate cancer. And if you look over the last 10 years, the death rates from prostate cancers have decreased by about 40%. The main reason for that is the PSA. It's not a perfect test though. Like any other screening test, there can be false positives and false negatives. And what I mean by that is somebody can have a high PSA and not have prostate cancer, and somebody can have a low PSA and have prostate cancer. That's where it comes in the baseline we talked about, following the PSA, consulting with your physician. All those become very important because the PSA can't stand by itself. I think the main benefit of receiving care at Shawnee Mission Medical Center is that Shawnee Mission group of physicians and their dedication toward being on the cutting edge of technology, patients can come here with confidence that they're getting the standard of care or above in any entity they're being treated for. This is Dr. Scott Montgomery. I am a board-certified urologist at Shawnee Mission Medical Center.